Welcome to our first video on bullous skin diseases. Let's begin. In this lecture, we will discuss bullous pemphigoid and pemphigus vulgaris. For each of these conditions, we will go through the definition, pathophysiology, risk factors, clinical presentation, diagnosis, and management. Let's discuss bullous pemphigoid first. Let's start with the definition. Bullous pemphigoid is an autoimmune disease caused by antibodies directed against the basement membrane of the skin, resulting in subepithelial blistering of the skin. It mostly affects the elderly and is associated with diabetes and rheumatoid arthritis. Now let's take a minute to understand the pathophysiology behind bullous pemphigoid. You should know that it is an autoimmune process with IgG autoantibodies directed against the hemidesmosomes in the basement membrane, resulting in their destruction. It is considered a type 2 hypersensitivity reaction. More specifically, autoantibodies bind main antigens such as BP180 and BP230 in the basement membrane, triggering an antibody-mediated complement activation. As a result, an acute inflammatory process develops. Proteases then destroy the hemidesmosomes, which normally keep the epidermis attached to the dermis. When these structures are destroyed, epidermal-dermal splitting occurs. This is an image that depicts the location of hemidesmosomes and desmosomes in the skin. Recall that hemidesmosomes are the cell structures that assist in attachment between basal keratinocytes and the basement membrane. Desmosomes, on the other hand, are cellular adhesion structures that provide cell-to-cell adhesion. Hemidesmosomes are the structures destroyed in bullous pemphigoid. Desmosomes are the targeted structures in pemphigus vulgaris, which we will discuss later on in this lecture. Now let's look at the possible risk factors. As we've already mentioned, age is one of the most common risk factors of this condition, since it typically affects the elderly population. Some neurological conditions such as epilepsy, multiple sclerosis, dementia, and Parkinson's disease are also considered to be risk factors. Lastly, burns, trauma, UV radiation, and radiation therapy can also contribute to the development of bullous pemphigoid. Let's continue with the clinical features. For the boards, you are expected to know the typical clinical presentation of patients with bullous pemphigoid. Usually, it'll be an elderly patient presenting with large, tense bullae filled with clear fluid that are intensely pruritic. In fact, weeks or months before developing the bullous lesions, patients may report a prodrome of pruritic lesions such as urticarial or eczematous lesions. It is important to know that bullous pemphigoid usually spares mucous membranes such as the oral mucosa. This is in contrast to pemphigus vulgaris, which we will see later, which commonly affects the oral mucosa. Note that typical locations for bullous pemphigoid are flexural surfaces such as the groin and the axilla. This is an image that shows numerous tense bullae that are characteristic of bullous pemphigoid. Now let's discuss the diagnostic approach. Patients with bullous pemphigoid will present with typical large tense bullae on a physical exam. Nikolsky's sign will be negative, meaning that upon applying light pressure on the lesions, no separation of the skin occurs. Let's take a minute to understand the mechanism behind the negative Nikolsky sign. When a lateral pressure is applied to the blister, the epidermal layer doesn't separate from the basal layer, and the blister remains intact. This means that it is difficult to rupture the bullae in bullous pemphigoid, because the skin's epidermal layer is intact. The diagnosis of bullous pemphigoid can be confirmed by a skin biopsy. For the boards, you are expected to know the classical histological and immunofluorescence findings. Histological exam will reveal splitting between the dermis and epidermis along with possible eosinophilic infiltrate. Direct immunofluorescence will show a linear band of IgG and C3 deposited along the basement membrane. Indirect immunofluorescence can also be done for the detection of circulating antibodies against BP180 and BP230. Finally, on CBC, one will usually have peripheral eosinophilia. This is an image of H&E findings of bullous pemphigoid. Here you can see the separation of epidermis from underlying dermis and presence of eosinophils. Here you see the immunofluorescence findings of bullous pemphigoid showing linear IgG deposits along the dermal-epidermal junction. Now let's discuss the treatment options. Bullous pemphigoid is less life-threatening than pemphigus vulgaris, but it can become potentially fatal. Despite that, patients usually respond well to treatment, with high-potency topical steroids being mainstay of treatment. So patients are started on both conservative and medical treatment with wound care, antiseptics, emollients, and dressings for blisters, and high-potency topical corticosteroids such as clobetasol. Systemic steroids such as prednisone can be used if topical steroids fail or are difficult to apply, although they are not considered to be more effective. Immunosuppressants such as azathioprine may also be required in extensive cases. A 70-year-old male comes to the physician due to itchy skin and blisters. He first noticed the blisters 3 months ago. Physical exam shows several large tense bullae bilaterally on his arms and thighs that do not rupture when lateral pressure is applied. Skin biopsy shows eosinophils in the bullous fluid. Antibodies against which structure are most likely present in this patient's plasma. This patient presents with classic signs and symptoms of bullous pemphigoid. Specifically, he has itchy skin and large tense bullae. These bullae do not rupture when lateral pressure is applied. This indicates a negative Nikolsky sign, characteristic of the bullae in bullous pemphigoid. The presence of eosinophils in the bullous fluid is also characteristic of bullous pemphigoid. As we explained in one of the previous slides, patients with bullous pemphigoid have antibodies against hemidesmosomes. Next, let's move on to pemphigus vulgaris. Let's start with the definition. Pemphigus vulgaris is a life-threatening autoimmune disease characterized by painful intraepithelial blisters that involve the skin and mucous membranes. It most commonly affects patients during middle to late adulthood, unlike bullous pemphigoid, which mostly affects the elderly. Let's take a minute and understand the pathophysiology behind the skin condition. Similarly to bullous pemphigoid, pemphigus vulgaris is a type 2 hypersensitivity reaction. In pemphigus vulgaris, IgG autoantibodies directed against desmosomes target proteins such as desmoglein 1 and desmoglein 3, resulting in their destruction. These proteins are present in desmosomes in keratinocytes, which keep cells bound together. This results in intraepidermal splitting and the development of flaccid bullae. Recall from our previous image that desmosomes are the structures that provide cell-to-cell adhesion. Therefore, when the antibodies destroy the desmosomal complexes via a type 2 hypersensitivity reaction, keratinocytes separate from each other and lead to intraepidermal splitting and the formation of fluid-filled blisters. Next, let's discuss the possible risk factors. Pemphigus vulgaris may be associated with myasthenia gravis, systemic lupus erythematosus, and thymomas. A patient with a family history of pemphigus vulgaris has an increased risk of developing the disease, suggesting a possible genetic link, with the highest incidence detected among patients of Jewish and Mediterranean descent. Drug-induced pemphigus vulgaris is often associated with medications such as antibodies like penicillins and cephalosporins, ACE inhibitors like captopril, NSAIDs like aspirin, and phenobarbital. Next, let's discuss the clinical presentation of pemphigus vulgaris. Typically, patients present with flaccid bullae that rupture easily, resulting in painful ulcers, erosions, and crusts. Usually, there is no associated pruritus, and frequently lesions start in the oral mucosa. This is in contrast to bullous pemphigoid, where intense pruritus occurs and the oral mucosa is spared. More specifically, patients may initially only present with oral pemphigus vulgaris. Patients with oral pemphigus vulgaris complain of painful oral blisters and erosions that can also spread to the larynx and pharynx and cause hoarseness along with difficulty with eating and drinking. It's important to note that other mucous membranes may also be involved. This includes the conjunctiva, vulva, vagina, and anus. Other locations where blisters can develop include areas subjected to pressure such as the axilla. Here you see an image showing the friability of epithelial tissue in the gingiva in a patient with pemphigus vulgaris of the oral mucosa. This is the result of the flaccid bullae easily rupturing upon manipulation. Now let's talk about the diagnostic approach. The initial step for the diagnosis of pemphigus vulgaris is performing a physical exam. Here, let's pay attention to a differentiating factor between bullous pemphigoid and pemphigus vulgaris that is found on examination and is often tested on exams. Compared to bullous pemphigoid, pemphigus vulgaris has a positive Nikolsky sign, which means that upon application of mild lateral pressure to the fluid-filled blister, a separation of the upper epidermal epithelial layer from the lower epidermal layer occurs. This is because of the desmosomal complexes that keep cells bound together are damaged, making these blisters very fragile and easily broken. Usually, a skin biopsy from the skin adjacent to the blister is required to confirm the diagnosis. Histology shows acantholytic cells that are the result of separated keratinocytes due to affected desmosomal junctions. Direct immunofluorescence is then performed and typically reveals a fishnet appearance due to IgG autoantibodies and complement deposition. Indirect immunofluorescence, or ELISA, can also be used for the detection of circulating autoantibodies against desmoglein 1 and 3. This is a histological image of Pemphigus vulgaris depicting acantholysis and tombstone appearance of the cells. Acantholysis is the result of floating keratinocytes that have lost intercellular connections, leading to sloughing of a superficial epithelium while leaving the basal layer of keratinocytes intact. This results in a finding that is often described as having a tombstone appearance with basal layer of keratinocytes looking like tombstones. Remember that acantholysis is only present in Pemphigus vulgaris. Hence, it is an important differentiating factor between Bullous pemphigoid and Pemphigus vulgaris. Here you see the direct immunofluorescence of Pemphigus vulgaris depicting the characteristic fishnet appearance of IgG autoantibodies. This is in contrast to the linear appearance that we saw in Bullous pemphigoid. Finally, let's discuss the treatment. The primary goal for the treatment is to decrease skin erosions and blisters in a timely manner, and to prevent infections since the condition can be fatal if left untreated. First-line treatment involves systemic steroids such as oral prednisone, prednisone, or IV bolus methylprednisolone. Corticosteroids are the best option for the reduction of mortality, but their long-term use has its detrimental side effects. Hence, in cases of severe steroid side effects, immunosuppressants such as azathioprine and mycophenolate mofetil can be used. As we've already mentioned, it is important to prevent infections over damaged skin, and for that, antibiotics are suggested. As an additional treatment, topical steroids can be used in conjunction with systemic steroids and can be helpful in persistent lesions. Lastly, local wound care is important to prevent infections as well as topical anesthetics, which can help with pain management, especially for oral lesions. A 45-year-old female comes to the physician due to pain in her mouth while eating. She first noticed deep, painful oral ulcers 6 months ago. Later, she started developing flaccid skin blisters that peel off easily on rubbing. Some blisters have ruptured spontaneously. She does not complain of itching. She was started on a cephalosporin for a UTI recently. What is the most likely pathophysiology of this patient's disease? This patient presents with classic signs and symptoms of Pemphigus vulgaris. She has deep, painful oral ulcers, flaccid skin blisters with a positive Nikolsky sign, and no pruritus. Medications such as ACE inhibitors and antibiotics such as penicillin and cephalosporins can induce the formation of antibodies in Pemphigus vulgaris and therefore are risk factors for the condition. Remember that Pemphigus vulgaris is a type 2 hypersensitivity disorder with anti-desmoglein 1 and anti-desmoglein 3 antibodies attacking and destroying desmosomes in the stratus spinosum. This results in flaccid bullae with a positive Nikolsky sign. Here's a table that summarizes some of the important features of the autoimmune blistering skin conditions. Take a moment to pause the video and review the key information we have covered in this lecture. A 50-year-old male comes to the physician due to skin blisters that he first noticed 5 months ago. Blisters have increased in size and some of them have ruptured. Past medical history is significant for essential hypertension treated with captopril. He is an executive chef in a restaurant, but he can no longer enjoy his own food because every time he eats, he feels severe pain in his mouth. His vital signs are a blood pressure of 100/70, heart rate of 99, respiratory rate of 15, and a temperature of 38 degrees Celsius. Physical exam shows multiple diffuse large bullae that rupture easily on manipulation. Which of the following is the best diagnostic test for this patient's condition? A. Skin biopsy with immunofluorescence staining. B. Anti-desmoglein antibody measurement in plasma. C. Anti-tissue transglutaminase antibody measurement in plasma. Or D. Anti-hemidesmosome antibody measurement in plasma. Before we decide what the best diagnostic test is for this patient, we should first diagnose him. The patient presents with skin blisters, some of which have ruptured. He also has oral pain while eating food, possibly suggesting oral ulcers. Flaccid bullae that ruptured easily on manipulation, and oral ulcers suggest Pemphigus vulgaris. He takes captopril for his hypertension. Captopril is known to cause medication-induced Pemphigus vulgaris. The best diagnostic test for pemphigus vulgaris, just like any other blistering skin disorder, is option A. Here is a slide reminding us of the diagnostic approach in cases of suspected pemphigus vulgaris. Now let's discuss why other options are incorrect. Although the anti-desmoglein antibody is characteristic of pemphigus vulgaris, measuring it in the plasma will not give us a tissue sample where we actually see antibody deposition around desmosomes. In other words, although reasonable, measuring anti-desmoglein antibody levels in plasma is not the most accurate diagnostic test, which is why option B is incorrect. Option C is incorrect because anti-tissue transglutaminase antibodies are associated with celiac disease and dermatitis herpetiformis, not pemphigus vulgaris. Option D is incorrect because anti-hemidesmosome antibodies are associated with bullous pemphigoid rather than pemphigus vulgaris. And that concludes our first lecture on bullous skin diseases.